Good evening, everyone. Thank you so much for joining us this evening. I'm going to hand this off to Mr. Jim Sinclair, who's our board chair for Fraser Health Authority.
Thank you, Victoria, and welcome everybody. This is an historic moment. It's the first ever virtual Fraser Health Public Board meeting. So thank you for joining us tonight. We hope that the information you'll get tonight will have made your time worth it. First of all, let me do something very important, and that's to acknowledge that the Fraser Health provides services within the ancestral, traditional, and unceded traditional lands of the Coast Salish and the Antlakam nations. Thank you all for joining us tonight. We try to make a priority to stay connected to our communities and the people we represent, and normally this meeting would be held in a community and you'd be welcome to come in person. We are all, like you, hoping that sometime in the near future we'll be back to doing that. First of all, let me thank all of you for making this meeting possible, particularly the technical staff who actually manage all of this and have managed the Zoom system and the virtual reality for the last period of time. I also want to say that the people who submitted questions, thank you very much for submitting questions. Tonight we will try and get to all of them. There's over 25 of them or 22 of them. We'll try to answer all those questions tonight. We will not be taking questions from the audience tonight. Perhaps we'll up our game at the next time if we continue to do this and make that happen. But I'm sure tonight we'll get through the questions. If we get through the questions we have, we'll be doing well. I also want to say that several of you put in your questions of a medical nature. And let me say that I have an honorary degree. They do call me a doctor, but I'm not going to be offering advice tonight. In fact, we encourage you to go to your medical team and get those answers from people who know what they're talking about. So a few words about Fraser Health and Fraser Health Board. We represent about 1.8 million people, which is no small amount. To give you some perspective, the closest health board that's in size-wise is Vancouver Coastal, and it's about 1.1 or 1.2. So we represent 600,000 more people than anybody else in the province, which means our job is a large job. It goes without saying that we have a very diverse and wonderful population from many different cultures. Let me start, first of all, by introducing the people that you're seeing here tonight from the board, anyway, to start with. Nicole Asland, Manpreet Gruel. You want to put your hands up? There you are. Good. See, there you are. Inderjeet Hundo, Opreet Kane, Tom Kim, Jesse LaHale, Joanne Mills, and Joanne Mills is not here, and Willie Charlie is not here, and Margaret Blamey could not make it tonight. The other two may be able to make it later in the meeting. And I also, you don't see, but the person who makes all of this possible, Christiane Taylor, is the board secretary at the board. The other people that have joined us tonight are the people that every day make this health authority work, along with, of course, all of people who deliver those services. And so they are represented here tonight by, of course, the person you can see and probably have come to see more often than not recently, Dr. Victoria Lee, who's the president and CEO of the authority. But joining her is Dr. Roy Morton, who's the vice president of medicine, Dermot Kelly, who's the vice president of quality, access, and flow. I'll get him to explain that to you someday. Norm Peters, the regional care integration, and Elizabeth Brodkin, who's the acting vice president, who stepped in to be the population health and chief medical officer. Linda Dempster, the president of pandemic preparedness and response, which is really a new job that's been created to help to make sure we're ready for the next potential surge. Brenda Leggett, who's the vice president of system optimization and making sure we don't spend more money than we have. Cameron Bryan, who's not with us tonight, who's the employee experience, and Naseem Narani, who's the vice president of communications and public affairs, and Brent Kershaw, vice president of informatics and technology and facilities. So again, we're here with you tonight to listen, to answer your questions and talk about our authority. I just want to make a couple of things. The board, those you don't know, the board is appointed by the government. We're usually on 1, 2, or 3-year terms, and we're up for appointment in a rotating manner. Our job is kind of pretty straightforward, although difficult some days. We have kind of 3 big areas. First of all, our job is to make sure that all of you get the best care possible. That's the bottom line. That's our job, to make sure the quality of care you're receiving is being delivered to you and being delivered to everybody in an equitable and culturally safe and sound way. And we continue to strive for this ideal all the time. Also, we're here to make sure that the directions that are given by the government and the money that we're being given by the government is carried out as they see fit, and to do that. And then with your help and the help of the citizens of our region, our job is to set the policies and directions to provide for present and future healthcare needs in the province, in our region, excuse me. We normally meet every 6 weeks or so, and we meet for 2 days, committee meetings, and regularly. Since the COVID pandemic, like a lot of people, we've been putting in some extra hours, so we've been meeting every week. And that's also very true, I would say, for the executive. They wish they were meeting every week, because that's a team that has made this place work night and day, really, for the last 3.5 months. So let me say to all of you, thank you very much for the work you're doing. COVID. It certainly is a worldwide challenge. It's certainly challenged this authority as we've never experienced before. We have probably the most cases in the province, probably equal to all the rest of the province put together. So that in itself is a challenge for us to meet. We had 79 deaths. I say that number fairly quickly, but those are 79 people that died from this disease, and that's very unfortunate. And of course, our feelings and our thoughts are with their families as this goes through. We had the long-term care homes became kind of a ticking time bomb in the country. 80% of the deaths in Canada came in long-term care facilities, which is a huge number. The outbreaks were massive. And I just want to say that I think thanks to our, what we call the SWAT team, but thanks to our public health officials who were everywhere, we had 22 outbreaks. We had 129 residents get sick, and we had 72 staff who were infected, and we had 44 deaths. And so we had one particularly difficult outbreak at Langley Lodge, where I believe almost over half of those deaths took place. We are profoundly thankful for the people that take care every day of the people in the system. Starting with long-term care, that was a huge job. Many of them working shorthanded day in and day out to make this happen. But also to all the healthcare workers out there, thank you. Every single one of you, from home support workers to care aides to housekeepers to healthcare professionals, nurses, doctors, radiologists, anesthesiologists, surgeons, food service workers. It's a huge, big team of people. And I just want to say that at this board, you're all important. Every job has a reason in the system. Every job makes the other jobs possible. And every job fits to a team that makes the healthcare for people the best we can provide. So I just want to say thank you to you and to the people listening and to the people at Fraser Health Authority. Your commitment to each other, to follow the rules, to take care of each other, to protect each other, to stay 6 feet apart, to wear masks, to close down your businesses, suffer the results of that, to lose your jobs, to suffer the results of that, to take care of family and friends and take care of each other. I saw so many kindness examples. I want to say we wouldn't be enjoying the situation we're in today, which is probably enviable to most places in North America and many places in the world, without all of you, because it's truly your actions that flattened the curve, that made it so that we could go to phase 2 and phase 3 and open up. And I think we can all say, looking to the south of the border, we can see very clearly without too much looking, that where they weren't able to have people work together, where they weren't able to flatten the curve, to dampen down the diseases, where it got out of control and they had to chase it. Let's say that the results are obvious, and that we would be, if we had not been successful collectively, we would be basically burying a lot more people would be sick, and the crisis would be dramatic. And what we see in the South, where they've opened up before they were ready, that's the result has been disastrous. Frankly, it's disastrous, and I think it's not over there down there. And I guess from my perspective, I'm in no hurry to reopen any borders with anybody at this point, particularly the United States. the first question I'm going to take a crack at, and then I'm going to turn the rest of the questions over. The first question is really, what are our priorities for the next year or two? Well, obviously, one of our number one priorities will continue to be the highest quality of care and safety and well-being of the people, and the safety and well-being of the people provided. I mean, we've asked a lot of healthcare workers in the last period of time, and one of the things we've asked was to risk their lives to go to work. And we're committed to trying to make that the safest possible job that you can have, and to provide you with the equipment you need to do the job. So that's really our number one priority. On COVID, we need to keep the curve flattened. Our commitment is to make sure we have the teams in place so that when we get a case, we're on it. That's the bottom line. That's how we stay healthy, is that as soon as a case is reported, our contact team is out there. Anybody you've come in contact with, we're chasing around. We chased 7,000 people in the last 3 months. And by chasing those 7,000 people, we probably prevented thousands of cases from being, in fact, people being infected, and from those people infecting another 7,000 people. So that's one of our highest priorities, is to keep that curve down by making sure the rules are being followed and we do the contact. The other issue with our priority is the fall. None of us can say accurately what will happen in the fall, but we do know that a number of people are predicting that there'll be a further outbreak and a surge in the fall. Hopefully, we won't have a surge in the summer. We will control this. People will follow the rules that are out there now, and we'll control it. And if we do a surge in the fall, we want to be prepared for it. So getting prepared for that's important. Our priorities include long-term care. You know, we had a great system. It worked very well. We can tell by our numbers, but it didn't always work. And right now, the province and the health authorities are working to put together a plan for the fall so that we can deal with some of the tough issues, including making sure people aren't going to work sick, making sure when there is an outbreak, we're on top of it, making sure the testing's being done properly. So we see long-term care facilities and making sure that our seniors are taken care of as a priority. Home support, we're going to make sure in the next year that home support continues to grow, develop, and the care becomes better. Surgeries. 30,000 people lost their surgeries. So we reopened our surgery in Fraser Health, and I'm happy to report that we are back to or above the levels of pre-COVID. What does that mean? That means that really people have really put their shoulder to the wheel, and that we're now in a case where we're back to, quote, normal in surgeries. And we've caught up about 30%, or I forget the exact number. We're catching up on those wait lists, and we're moving forward. But that was only the first phase. And the second phase, a priority, is to expand surgery to fill weekends and 2 more hours on each day. It's about a 30% expansion in surgeries, and the government has declared this is their objectives. They've given us resources to do it, and that's going to be one of our jobs, because if we don't do that, then that wait list will be longer for years. If we do that, we'll not only catch up with the wait list, but we will actually give people surgery faster. And that's a real priority for us. And finally, I won't spend any more time. There's always many other priorities, but there's been 2 epidemics in British Columbia. And the first, obviously, the COVID, but the second was the opioid crisis. And it's not a good news story to sit here tonight, or something we can be proud of, to say that the number of people that have died of this epidemic has gone up during the crisis. It's particularly gone up in First Nations communities and Indigenous communities, but it's gone up everywhere. And we know that we have more work to do on that front, which isn't to say there aren't thousands of people alive today because of the work of community people, first responders, public health officials, etc. But we have no work to do. And carrying on with the Indigenous, one of our priorities is going to be making sure that when you come from the Indigenous community into a Fraser Health Authority, you are treated with respect and you receive the same care as everybody else. It's one of the basic tenets of the public healthcare system that it is for everyone equally. That's the whole point. There's not more important people than others. And I can say safely, I think we all can admit that we have a ways to go yet in making sure that racism is gone from our system, whether it's practiced against Indigenous people or other people of color. It doesn't matter. Racism is an evil disease that has killed thousands over the years, particularly in Indigenous communities, and it needs to end. And we are committed to taking action, further actions to solve that problem. So thank you for listening. I appreciate the questions. And let me start with the first one. What is the health authority doing to reduce racism in healthcare, particularly for Black, South Asian, Asian Canadians, assessing Fraser Health emergency departments and maternity care, which really follows on the last comment I made.
Thank you for that very important question. So in Fraser Health, as Jim had outlined, we serve 1.8 million people, and the people that we serve are very diverse. About 90% of refugees and 40% of newcomers reside in our region, and 42% of the population is actually of visible minorities. So how we interact with our patients and families and with each other in our context, especially in health services where there's a lot of vulnerable people, very, very important to us. So that's driven by our diversity policy, which is embedded in everyday interactions, as well as our care planning, as well as how we design and deliver our services. So it's embedded throughout, and we also ensure that our workforce is reflected in that diversity and multiculturalism, and that we embrace equity as well as pluralism. And I think that's been an area that we have put a lot of effort and time and resources to do better. And I think there's, of course, more opportunities as well, specifically in the Indigenous population as well. We, of course, as one of the health authorities, signed on the Declaration for Cultural Safety and Humility in 2015, have been reviewing our policies, practices, and more recently have done a review and are continuing to look at how we can improve our actions to reduce systemic racism, as well as ensure that there's better care, as well as better health outcomes that we see across all of our populations, and especially those that are most vulnerable.
Thank you, Victoria. Any other comments about that? Okay. The next question is from Greg McCone in Abbotsford. Since working from home where possible reduces air pollution, contributing to respiratory disease, greenhouse gas emissions, contributing to climate change, stress from time spent in traffic, risk of accident while commuting, costs associated with providing office space. Does the Fraser Health Board view working from home to be an essential component of Fraser Health's responsibility for a healthy workforce, fighting climate change, and fiscal responsibility? Dr. Lee?
Thank you. I think that's working from home is one of the factors that we consider in looking at climate change actions, a healthy workforce, as well as being fiscally responsible. Of course, there's many, many other areas that we look at, and we do have work from home policies where it's appropriate and effective. And in fact, during COVID-19 period and continuing throughout, we have significantly increased our infrastructure to support those that are working from home. And that includes IMIT support, as well as workplace health supports, as well as HHR, so employee experience support. So a significant amount of resources have gone into ensuring that people that can work effectively and appropriately at home are well supported as well. So similar to other industries in healthcare, we've done a lot of work in this area, but of course, most of the services that we provide in health are on the ground by providing health services, whether it's in the community setting or in our acute setting where it's not possible to work from home. So it's a mixed picture across the board.
Other comments or anything? I think it's a good question. You know, I never would have imagined the number of people working at home today. And I think we need to look seriously at if there's places where it makes sense for people to work at home, then if I was driving an hour and a half to go to work or an hour to work every day, I'd be thinking about working at home too, I can tell you, if it's possible. That was a good question. Kim and Sue F. From Port Coquitlam. When will hospitals have tablets or cell phones available for patients? If we can't visit them in the hospitals, it would be great if we can FaceTime or speak with them. When can we expect visitors to be allowed in hospitals? With all the technology available, this should not be difficult. I'm sure the wireless carriers would help facilitate this. So there's really two questions. One is, when can we have visitors? I expect visitors in hospitals. And two, what about the technology? And Brent, are you going to answer that, or Victoria?
I can start. In terms of the second part around visitors, of course, as you mentioned, Jim, earlier, safety of our patients as well as staff is of utmost importance for us. And one of the areas that we had implemented early on with COVID-19 was to have an essential visitor policy, and that continues through the COVID-19 period, as well as now into recovery. I think it's been challenging, not only for our staff, medical staff, but also, of course, the families and patients. And I think that's one of the sacrifices that you had alluded to earlier this evening, about all the sacrifices that people have made to flatten the curve. And with that, we also wanted to make sure that we enable virtual visits as much as possible. And we have mobilized over 400 tablets in the system very quickly for providing clinical care, as well as for virtual visitations with the loved ones. And in doing so, I should also acknowledge our partners with foundations and community donors that have been quite generous in providing us with more of those tablets. And what we have been able to do is utilize those for virtual visits. But where it's not possible, for instance, of course, the clinicians are there first and foremost for clinical services. So where they're busy with clinical care or otherwise occupied with other patients, sometimes it might be difficult to facilitate, but overall, virtual visits have occurred through tablets and other services. In terms of Wi-Fi services, we do have Wi-Fi services across all of our 12 hospitals. However, access to that Wi-Fi from patients and the public and the family is an area that we are currently working on to expand.
Okay, good. Any other comments about high tech in the hospitals? Actually, it's probably not high tech anymore to most people.
Yeah, I think we're good with that one.
The next question is from Janet Coates from Agassiz. What is being done to fix the deficiencies in the for-profit long-term care facilities that led to the vast majority of COVID deaths in BC occurring in these places? What legislative regulatory oversight has been put in place to ensure compliance? What is Fraser Health doing to substantially increase funding and support for seniors wishing to stay at home? And do you routinely confer with the BC Seniors Advocate, Isabel McKenzie, and utilize her research and recommendations for developing policies? I'll take a quick shot at that one. So on the last question, Isabel McKenzie, she is a treasurer for the province of British Columbia. Her reports are well read at the Health Authority. I spent, the chairs of the authorities have met with her and spent recently an hour with her talking about funding policies for long-term care facilities because of the problems with those. So yes, we do consult, and we do consider her an ally and a real help. She provides real insight for people and advocate. Funding to stay home. There has been increased funding for the last 3 years for home support workers. We are revamping our system. We have in the last 12 months brought it back and made it all under the public sector again, which we think has increased efficiency and effectiveness of the system. But we're not done. We have more work that we're doing. We're looking at now how we can do more cluster care, how we can have more consistency for people who don't see 10 or 15 different people in a week, that might have teams of clusters that we do. Some places looking at more of that, and connecting everything from the community health nurse to the home support worker, to the occupational therapist, to all of that. So we are absolutely committed to keeping people at home and looking at ways to do that. On the final question, which was really what is being done to fix the deficiencies in the for-profit system, really it comes down to making sure that whether you're a for-profit or a non-profit or a Fraser Health Authority run facility, are you doing a good job in protecting the people and giving them quality care? And so we do have oversight. We do have inspectors that go in. We're looking obviously at doing more of that, certainly for the next 6 months to a year as we continue to battle the COVID crisis. We have taken some steps. The provincial government mandated, as well as ourselves, that We did not want workers traveling back and forth between 2, 3 or 4 sites because of the potential spread of the disease. So we did an enormous job to take 5,000 workers and assign them to individual sites, only one site. And in doing that, we also guaranteed them 40 hours of work a week. There was a rotating, underpaid, undervalued workforce in long-term care, casual labor that didn't have benefits or steady work, and that wasn't good for healthcare or for them. So today they're getting the highest union wage, not the benefits, but the wage, and they're being guaranteed 40 hours of work a week. I don't believe this board believes that that should disappear. That if COVID ends, we shouldn't go back to that situation where we had that transient labor and low-paid people trying to take care of our seniors and precious people. And so there are changes coming on that front as well. I can assure you by the time we get to the fall, there'll be a whole list of recommendations that we've looked at and implemented to make sure that as we hit the fall, we are on top of that again. So again, that's a good question, and one that I think will be asked many times across this country over the next 6 months. There's already been 2 major reports that I've seen, and probably a royal commission at some point, I suggest, that would be looking at the same thing. Anybody else want to add to that?
Yeah, I'll add a couple of parts to that. We've been able to successfully manage 22 outbreaks in our setting, and that's long-term care, assisted living, independent living types of settings. We in Fraser Health worked very proactively across our region as well as partners in the facilities to ensure that we provide both preventive measures as well as mitigation response measures. Where there wasn't an outbreak, we immediately implemented quite a wide variety of infection prevention, control, environmental, public health, and clinical operational measures in place very quickly to prevent COVID-19 being introduced in the first place. And where there is even one case, we implemented quite a comprehensive SWAT team approach to dealing with those outbreaks in a very effective and efficient manner with our partners, whether they're contracted facilities or private facilities. And it's important to note, of the outbreaks that we have seen, there hasn't been a significant difference between private, so for-profit, versus contracted facilities that are not for profit. So I think that's also important to note, that we haven't seen a difference between contracted facilities in the outbreak. And I think we need to also acknowledge that the contracted facilities and healthcare workers on the ground have done a fantastic job of taking care of those very, very vulnerable people, and really heroic efforts have been made to safeguard those facilities as well as individual residents' health and well-being. And I know that it's been a very, very challenging time for all because of many of the restrictions, including visitor policies that's been in place. And again, huge acknowledgement to the families that have also sacrificed during this difficult time to manage these outbreaks as well. I want to pass it over to Norm Peters, our VP for Regional Care Integration, to talk a little bit more specifically about some of the work that we have done with Isabel McKenzie, to add to what Jim had just mentioned.
Good evening, and thank you for that, Victoria. So as Jim alluded to, Isabel McKenzie, the Seniors Advocate, provides an important voice for seniors across British Columbia and in the Fraser Health area. And a number of her reports and recommendations have helped guide provincial direction with respect to providing support to seniors in the community. A best example of that would be her report that focused on the direct care hours that are being provided into long-term care. And as part of a provincial commitment by the government and based on Isabel's report, the care hours in long-term care facilities were increased. So she's a critical part of helping to advance and support and advocate on behalf of seniors. And just building on a few comments from Jim and Victoria, at the height of our response, we had over 500 Fraser Health staff deployed out into long-term care and assisted living facilities to help manage the outbreaks as they occurred. And we also continue to provide services through home health and home support. There has been some of the services that we would traditionally provide have been stood down during COVID, such as in-facility respite and adult day programs. So we've shifted our focus to providing more virtual services, as well as enhancing in-home respite so that seniors will be able to be cared for safely within their home. And it's one of our ongoing strategies to help meet the growing demand for seniors within the Fraser Health region.
That's great. Just another point to that question, Isabel's report. She did talk to us about the funding model. And she said, well, we can talk about the care, that in general, the average amount the private sector spends per patient compared to the nonprofit and the public sector is around $10,000 less per patient or per resident. So there's a significant issue for her there that we need to address when we're discussing how to fund this and make sure that people get the best care possible. And that was in her last report. The next question is from for Linda Dempster. I volunteer at Cottage in Worthington. When will volunteers be allowed to return to care homes? I guess that is a question that could apply to acute care facilities in many places. So I've got either Dr. Lee or Linda.
Yeah, thanks, Jim. Volunteers play a very important role in all of our long-term care facilities. And I think last Tuesday, most people would know that the Ministry of Health actually released some new guidelines for visitors in long-term care. These are currently posted on our website. There are provisions for other visitors, such as hairstylists as well, within those policies and those guidelines. So the ask is that each long-term care facility is actually being asked to review the guidelines and determine their own processes. So this would include appropriate places for visitation, such as single rooms or providing spaces outside or in larger areas so that people can actually physically distance. In addition, all visitors are being asked to do the following. They're being asked to do not enter the facility if they're sick, wash their hands before and after visiting anyone. They're required to bring and wear a mask, and they're required to maintain 2 meters of distance, obviously, and to stay in those designated visiting areas. And there is only to be one visitor per resident at that time, and appointments must be made with the facility to do this. So if the long-term care facility can meet the requirements as set out by these new guidelines, then volunteers may be included in that. However, each facility may be different depending on their physical layout, their ability to support physical distancing, and their ability to maintain the rest of the guidelines. So, I think volunteers are very important, and we rely on volunteers. We have upwards of 8,000 volunteers across Fraser Health, including in long-term care, and we value everything that they do for us. So if there are other roles that volunteers could play, that is another option within this time. So I think it's going to be up to the individual facility. And if you as a volunteer want to suggest something else that you might be able to do to help the facility, I think that's a very valid point. So thank you for that great question.
Great, thank you. The next question is from Laurie Thornes. He's the MLA for Chilliwack, Kent. And his question is basically, he made a presentation to the board recently or before about the extreme shortage of family physicians in Chilliwack, which will only get worse as baby boomer physicians retire. What is the board doing to rectify this worsening situation? And that's for Norm.
Good evening again, and thank you for this really important question because this is one of the critical priorities for the provincial government and for Fraser Health. And and all residents of the Fraser Health region are impacted by having access to good primary care in the community. I think it's important to note that a critical partner in the recruitment and attraction of new GPs into a community is our 10 divisions of family practice. These divisions are organized according to community and are supported through the Doctors of BC to help recruit and attract physicians into their individual communities. And Fraser Health has a critical role to help support them in doing that work. And what we have been doing as part of a ministry priority has been paying increased attention to the primary care networks, which is increasing capacity for primary care through not only attracting new GPs into a community, but also investing in what we call team-based care. And that is having additional resources such as NPs, nurses, social work, and other allied health professions that work alongside a GP to help increase the capacity of that GP. Not all issues that a individual comes to a GP for needs to be seen by the GP and can be quite easily seen by a nurse or an NP, thereby freeing up the GP to see more of the complex individuals they see in their office. So we have a overall plan to increase and support the primary care networks across Fraser Health. In Chilliwack in particular, it's what we call Wave 2 community, and we will be increasing and investing in additional resources. In terms of the recruitment of GPs into that community, there are several mechanisms, and these are similar to other communities. We look to a residency program to attract new physicians to practice and help to encourage them to stay in their communities. And then we have also what we call return of service physicians that we use to help augment and support family practice in communities. So there are a number of strategies that Fraser Health through the divisions of family practice are looking at to engage and increase the capacity of GPs in all communities within Fraser Health.
Thanks, Norm. Any other comments about that? It's certainly not a new problem, but it's one we're going to have to face head on. The next question is it's a question we've had before, and it's a good one. Is there a point when people are going to be told where the cases are in Fraser Health by community? And that recent survey to find out who has been sick with COVID-like symptoms being used, and will there be a follow-up testing? So the data on the recent survey, how is that being used? And can Fraser Health post daily or regular updates specific to each city or community? And that's one for Dr. Brodkin.
Thank you for that excellent question. So the ways in which COVID-19 data is reported out across the province is determined by our provincial health officer, Dr. Bonnie Henry. And she has walked a very fine line between keeping the public informed, particularly about where areas of risk and outbreaks might be, and not creating stigma in communities that might prevent people in those communities from accessing care. So at present, she is reporting information down to the health service delivery area level, which means that within Fraser, we have data that is reported by Fraser North, Fraser South, and Fraser East, but she has not yet given us permission to report to the community level, and that may not come for some time, if ever. So we are reporting as much data as we can, but ultimately the data that we can report is determined by our provincial health officer. To answer the second question, the BC COVID-19 population health survey was done in order to inform public health about community members' perceptions about COVID-19 and the risk and appropriate strategies that we might employ. And it's being used to inform our decision-making about testing, about management of cases and contacts, about areas of risk and stigma, and ways in which we might develop policy going forward. So thank you to all who participated in that survey, and as opportunities are made available for people who participated in the survey, say to take part in community-based testing for antibodies for COVID-19, they would certainly be made aware of those opportunities.
Thank you, Doctor. Don't go away. There's two more coming. This is a sort of a large question about the impact of a bituminous oil spill from a TransCanada pipeline the health impact of emissions from a diluted bitumen spill from Trans-Canada Pipeline on residents in Abbotsford and Chilliwack. Don't know if we have much to offer for that, but your thoughts?
Well, you're quite right that oversight of the pipeline and monitoring the impacts of a spill actually rests with the Ministry of the Environment, not with the Ministry of Health. That being said, when there is a spill, there is immediate and close communication between Health Emergency Management BC and the local public health. And local public health is responsible for advising the emergency responders about the steps that they must take to protect the health of the local residents, and particularly the most vulnerable. So an example would be the recent spill at the Sumas pump station, where our local public health was kept informed in real time about the impacts on the air and the local drinking water, and was able to support emergency management BC and ensuring that there were no significant effects that resulted to the population as a result of that spill.
Thanks. This one is from Joel Short. That was from Lynn Perrin, by the way, from Abbotsford. This one is, in some countries, people who are asked to self-isolate are either required or given the option to move into a designated hotel in order to avoid contact with family or housemates. Transmission within families is difficult to avoid, especially for people who share small apartments. Has this measure been considered in British Columbia?
Yes, it has. And so we take a variety of approaches depending on the situation. In Fraser Health, we have a lot of large multi-generational families that share a single home. And when we see COVID-19 cases in those homes, our public health nurses work very closely with the people living there to ensure that the people who are infected are able to effectively self-isolate from the other family members. And sometimes that means assigning them a particular room or educating them about how to clean up behind themselves when they use a common area like a kitchen or a bathroom. And for those who are entirely without homes where they can isolate, we have worked with BC Housing to create emergency response centers. These are centers that are located in the various communities. The physical space is managed by BC Housing, and the services that are provided within that space are supported by Fraser Health to ensure that people who have no other environment are able to successfully self-isolate.
Mm-hmm. You know, it's important to think about the context for that. One of the things this province has done that other provinces didn't do, that when people came into town, came in from out of the country to work in the fields as farm workers, they were isolated in hotels. They were given their own rooms and sent to hotels. And we came up, I think, with 6 to 10 people who had the disease that didn't go out to the fields. And so we prevented the spread. In Ontario, where they actually let the isolation happen on the farm site in most cases, they now had, I think, 1,000 cases and at least 3 deaths and about 4 or 6 or 8 major contaminations. So, you know, even simple things like that, getting people to quarantine when they come into the country is so important, because once it gets out into the community, then you're stuck. And so I applaud that. And I think it's a good idea to do it more often because it is difficult. And I know we have outbreaks in some communities where we have large numbers of people living and sharing accommodation. And then it does get to be a challenge. The next question is from M. Allister and D. Winkler. I've noticed CISO guidelines and application process to be onerous and extensive, especially for seniors and those with second language. Why is so much detail requested and needed by Fraser Health? Is this meant to be a deterrent to requesting this type of assistance? Furthermore, why does an annual review need to be conducted when it is likely the client's needs are going to diminish? Not going to diminish. And what would lead you to believe more than one review per year would be needed or necessary if it's not been asked for by the recipient? CISO is an acronym. It's really for the money that we provide to some people who are disabled with disability challenges. We provide them money to hire their own help. And so that's how the system works. And I don't know, maybe Norm or Victoria, I'm not sure how many people in our region have it. I've had at least one good presentation from the organization representing those people. So it is a debate. I don't know, Norm, or who wants to answer that one?
Yeah, thank you for that, Jim. I can answer further. So the CISO program, which stands for Choices in Support for Independent Living, as Jim described, is a program for eligible home health clients that are receiving home support to be self-funded for them to be able to organize, plan, and deliver their own home support services either directly themselves or through a client support group if they need assistance. The policies and procedures for the application and assessment process are set provincially. So that requires the health authority to follow those policies to ensure that people that are applying are best able to organize and meet their care needs through the self-funding approach, as well as the assessment is quite critical. All clients that are receiving home and community care services are to be reassessed on a regular basis, ideally within 1 year, or unless their care needs change, to ensure that the health authority has the most accurate and up-to-date information about individual care needs. So we can not only plan for their care needs, but also be able to plan more globally for meeting all care needs in the community. So the reason why we have that reassessment process, as this question points out, is that more often than not, the needs are increasing, and we want to make sure that the resources that are being provided are meeting those needs. Now, to help manage the issue that was raised around things like language barrier or some of the challenges about applying and being accepted to the program, we now have dedicated case managers who are working closely with all clients and those that are interested in the program to help them through the process to ensure that there is a much more engagement on the part of Fraser Health to ensure a successful implementation of a CECL client.
Thanks you very much, Norm. The next question is from Anita Parkinson in Delta. My questions are around the planning, your planning for the provision of MAID in Fraser Health and in Delta in particular. How many beds are you planning for? Currently, how many beds are available in each of the communities in Fraser Health region? Will these beds be reserved exclusively for the provision of MAID? So I think I can answer that fairly quickly. Beds aren't set aside for MAID services. We decided as a board 2.5 years ago that hospices under our authority would allow MAID services to be provided. And we had an issue with the Delta Hospice Society that refused to do that. And otherwise, unless you're a religious hospice, then you are obligated to provide MAID services. And it doesn't mean anybody's forced to provide them. They usually come from the outside, but you're provided it. In Delta, our position has been from all along that hospice should be providing MAID services for people in Delta. There are 10 beds there, and we expect to continue providing 10 beds there, and expecting to provide 10 beds where MAID services will be available, as is their right under the laws of Canada. We generally support MAID as a legitimate medical procedure that allows people to make choices that belong to them. Right now, we have served a 1-year notice to the Delta Hospice Society that we will no longer be continuing their contract, and that expires in 12 months from February. And after that, we will continue to provide Delta Hospice services in Delta. I don't know if you want to add anything to that, Norm, but that's basically what the board's position has been.
Yeah, just a few additional comments, Jim, just to build on and answer some parts of the question around dedicated beds. So there is one bed at Queen's Park, which is used for individuals coming from St. Michael's, which is a long-term care facility that has hospice. But as Jim pointed out, it's a faith-based denominational organization. So they, under provincial policy, have an exemption from providing medical assistance in dying within their facility. So we do have that available for individuals that are looking for receiving MAID services if they're in that location. But generally, we do not designate beds for MAID specifically. We consider it to be part of an overall approach to providing care, and that we respect individuals' rights to receive the services wherever they may reside, including their home, long-term care, assisted living, or hospice settings. And in fact, the majority of medical assistance in dying procedures are performed within individuals' homes. And that's why we have a team of providers that are available to help support people and respect their wishes to receive that service wherever they may want to, and provide it in a considered way that respects the wishes of the individual.
Great, thanks, Norm. Next question, moving along. Why is Fraser the most behind on cloud technologies? Ministry of Health has already provided proof of concept running in Azure. I don't know if I got all that right. Providence and Coastal have Amazon AWS running at least 6 months now too, even if it's just pilot stages. Fraser Health has a bad reputation for being overly conservative in adopting new technologies. This needs to change ASAP. Brent, you get that one.
Hi, thanks for that. Thanks for that question. I'll start by just acknowledging Fraser Health really does see the benefit and the potential of cloud-based technologies and cloud computing. Efficiency, availability, scalability, there's the benefits of cloud computing are well documented. That said, there is often a trade-off. One is visibility into the network performance you're reliant on, as well as the security there. Having said that, Fraser Health is not shying away from the cloud. We actually have multiple utilizations of the cloud underway right now. Our deployment of Microsoft Teams for the organization is cloud-based. We are running a data analytics trial on the cloud, and several other solutions as well. We're leveraging the cloud. Further, for us, and this is something in my role that excites me, is the possibility of software as a service. And we're certainly not shying away from that as a solution, leveraging the cloud for numerous applications. Now, having said that, I'll speak to the second half of the question about perhaps being cautious. And I will just note that the data that Fraser Health is responsible to act as custodian of and to ensure the privacy and security of is extremely sensitive and extremely valuable. And if we're criticized for moving too slow, I'll accept that criticism and I'll take it, because what we're trying to do is ensure that all of our processes and all of our tools are adequately secure and sound, just given the sensitivity of the information we're working with.
Jim, you're on mute.
Are there requirements for location, placement, visibility of signage when a body of water is closed due to E. coli? Acceptable to be posted in areas where people may or may not see it, or should sign barriers be placed at a shoreline or multiple areas? Who is responsible for posting warning signs? Harrison Hot Springs Lagoon signage has not been visible to many people in the past on a washroom building and by a playground. When signs are placed by signs by water, they were flimsy, falling apart only in one spot of the shoreline up a short time. Dr. Broderick.
Thank you for that question. So it is the responsibility of the owner of a beach or water property to monitor the quality of that water. In most cases, that is a local government. So in the particular example that's provided, it would be the city of the village of Harrison that is responsible for monitoring the water quality in that lagoon. They would also be responsible for posting signage if there was a problem with the water quality. There are guidelines in the Canadian Guidelines for Recreational Water Quality that state that the signage has to be prominent and visible. And if that is not the case, then it would be appropriate to register a complaint. If we received a complaint, we would investigate, but ultimately refer it back to the owner of the beach, which in this case is the village of Harrison.
So I would consider this actually, doctor, a complaint. So I would assume that maybe you would investigate that. Would that be possible?
We could certainly look into it, but ultimately the enforcement, the enforcement of the requirement of the Canadian Guidelines for Recreational Water Quality is with the village of Harrison.
Yes, right. But do we oversee them then to make sure they do their job, or does anybody oversee them to make sure they do their job?
If there was a particularly egregious example where somebody was not respecting those guidelines, then we probably would get involved. But in general, we would start by encouraging the owner of the property in question to do what they are bound to do under those guidelines.
Yeah, that makes sense. That's all I was really asking. It's good. Okay. This is from Stephen Nev in Langley, BC. I am so happy and grateful to all the board of directors. There you go. My question is, what is Fraser Health plans to ensure help is put in place for people who are struggling with addictive behaviors due to COVID-19? For example, long-term online recovery meetings like Smart Recovery or AA to help the long-term effects of this epidemic. Follow up with this question, why hasn't Smart Recovery been added to the Fraser Health website as an alternative to AA meetings. I guess I'm not sure who is going to handle that one. Norm, are you going to take that one? Good.
I am. So, so thank you for this important question, because this is an area that we're obviously quite concerned about, that there is still an ongoing healthcare crisis within our opioid related deaths, and we need to continue to strengthen our response to help provide support and services to people that are requiring that help. One of the benefits that arose during our response to COVID-19 has been the ability to shift some of our mental health and substance use services to virtual, including things like group sessions that shifted to virtual, and where we saw increased participation rates continue at a higher rate than prior to COVID-19. But in this area, we've implemented a virtual addictions access service that augments our rapid addiction access service to allow people to receive the supports virtually, to ensure we can maintain the physical distancing that's required at this time. And we've also put a number of online resources, including the SMART program, that's available for people to access at the Fraser Health website. So on the website, it's under the Mental Health and Substance Use Program, and those services are available for people to access. And we've been using social media to help promote and encourage people to access these resources. At last counts, between Twitter and other social media, we reached out to over 100,000 residents of the Fraser Valley area to ensure that they were aware of these important services.
Great, thank you. The next question. It comes from Wilf Hartman from Maple Ridge. What additional supports for housing for the homeless in Maple Ridge will you be providing? There appears little supportive housing in Maple Ridge beyond the two modular complexes on Royal Crescent and on Burnett Street. Have you been in touch with Mayor Morden and Maple Ridge Council on this, and what has been their reaction? I don't know whether Norm is handling that, or Victoria, you want to take a shot at that one?
Norm can go ahead with this one as well. Go ahead, Norm.
So we work closely with all local governments and municipalities on providing support to services within supportive housing. A key partner in this work is BC Housing, who is the lead government agency responsible for providing access to additional housing services for people that are looking to end homelessness and find a safe place to be housed. So wherever BC Housing is establishing supportive housing and they have the needs of our mental health and substance use program, we work in close partnership with them to provide both in-reach services from our programs, as well as at times set up services within those locations. And we have done that in all areas within Fraser Health, including Maple Ridge. There is ongoing work that I'm aware of involving the municipality, the Salvation Army, and BC Housing around temporary shelter beds within Maple Ridge, but we remain committed to working with all partners that are looking at housing solutions and making sure that Fraser Health is there to provide those important mental health and substance use services as needed for housing projects.
Okay, thanks, Norm. We have time for one more, I think, which follows on that one. Why hasn't Fraser Health opened an overdose prevention site in Maple Ridge due to the closure of Anita Place, Tent City, almost 1 year ago? De facto ops, people who use drugs and who are homeless in Maple Ridge are forced to use outdoors in parks, public doorways, empty lots, etc. I'm aware our mayor and city council oppose opening an ops in our community, but politics have no place in addressing the healthcare crisis as tragically evidenced in the US. Thank you for your consideration.
And thank you for that somewhat challenging question. Fraser Health does provide overdose prevention services in Maple Ridge, and these come in a number of forms. Fraser Health supports the app that was launched by the Provincial Health Services Authority called Lifeguard, which allows a user to download an app onto their phone and set an alarm, which will eventually trigger a call to 911 if the appropriate steps aren't taken. We fund peer outreach services through Rain City that include, among other things, the retrieval of discarded drug paraphernalia. And finally, we do provide overdose prevention services at some specific sites, modular housing units such as the Alouette Heights service. However, we are also actively pursuing creating a permanent overdose prevention site in the city of Maple Ridge. And we're working with the local community, with the landlords, and with the province to try to find a space that would be appropriate for those services.
Thank you. That's great. Maybe one more question though. We got. That's good. There's one last question. We might as well take the last question. I'm not sure. 70% hike in involuntary admission. What improvements would the health authority make to properly screen patients and ensure that only those required to have inpatient care receive it? Struggling parents can't find necessary spaces for their children. Legal rights of patients are often lacking or unavailable. What plan can be made to correct this and patient rights issues? Would the health authority and ministry establish a collaborative working group involving all stakeholders on the issue? I'm not quite sure, so if somebody can understand the context for that. That was from Carla Evans in New West.
Jim, it's Norm. So I will endeavor. I think there are two parts to the question. One, firstly, focusing on the involuntary admissions under the Mental Health Act, and the other one focusing on access to services for youth. So we'll start with the former first around the Mental Health Act. In 2019, the BC Ombudsperson issued a report on the Mental Health Act, which made a number of recommendations, including recommendations around strengthening patient rights for those that are admitted involuntarily under the Mental Health Act. In order to move forward with those recommendations, there is a provincial working group that is involving all of the health authorities and the Ministry of Mental Health and Addictions to implement those recommendations. And one of the key areas has been a focus on ensuring a proactive approach to patient rights for those admitted involuntarily under the Mental Health Act. In terms of the increase rate, I'm not entirely sure where the statistic came from, but I can speak a little bit to the process where more often the majority of admissions under the Mental Health Act are occurring in our emergency rooms when there is the need to admit somebody to an inpatient psychiatric unit, and the Mental Health Act is used to admit them involuntarily under the Act. There's a very rigorous process that's involved in making that decision. It's not something that's undertaken lightly. It starts with the attending physician, the psychiatrist in the hospital, and the psychiatric nurse working in a team approach to assess that person's needs. And ultimately, our objective is to provide that urgent response to help stabilize the person and then move quickly to a different approach to care that we can either support them ongoing within a hospital or a facility setting, or to effectively support their discharge to community resources. As part of the recommendations coming out of that ombudsperson's report was to improve the reporting to family members to ensure that there is someone that's aware that these steps are being taken, that that patient that's been involuntarily admitted will have access to a family member or other supports to be there as an advocate on their behalf. So we're very committed to ensuring that there's an open and fair and transparent process that balances all the various competing demands, including the rights of the individual, as well as also ensuring that we have a proactive and strong clinical response to help people in the moment of crisis. With respect to access for youth services, we have a number of programs. The most common one is our CAPSU program, where we actively ensure that there's good access to that program. On any given day, between 85 and 90% of the bed capacity is being used, so we do have availability. And we do, again, focus on ensuring that the services that are needed at an acute phase are provided, but then we are quickly moving to support the person, in this case, the young person, to be discharged and supported in the community. So I'm hoping that I was able to answer the questions presented.
Thank you. It's 8 o'clock, but I've got one last question. And if somebody actually hung around for an hour to hear their question, I can't really not read it. Besides, Dermot hasn't had a chance to say a word. So it's very straightforward. The population growth estimates in tens of thousands in the Tri-Cities. What are the long-term plans for Eagle Ridge Hospital? Why is it that EHR is still not a full-service hospital when it serves such a large community already? As an example, to not be able to give birth within a hospital in this community seems crazy. And I have Dermot beside that one.
All right, thanks, Jim.
Good evening.
Sorry, yeah, so as mentioned previously, I mean, Fraser Health is the largest growing health authority in the province. And as such, we actually work across our entire system through all of our acute care facilities and to ensure that we have a synergistic approach to the way that we deliver care and services. For Eagle Ridge specifically, even when Eagle Ridge was built back in the 1980s, they worked in a very, very symbiotic relationship with Royal Columbian Hospital to ensure that we have the full coverage of services for those communities and delivering those services across both of those communities. And many of those services go back and forth, such as surgery, there's anesthesia, and the emergency room physicians. So across both of those, it's able to deliver the services for the communities of the Tri-Cities.
Great, thanks very much. And we did recently just increase the emergency room there, I thought.
Yes, it is part of the new redevelopment process that is happening, is looking at the emergency department at Eagle Ridge.
Yes, yeah, that's what I thought. Anyway, that was our last question that was posted. So thank you to the entire staff who are here tonight, working overtime as usual, to answer all these questions. And you get a flavor of some of the complexities of them if you're listening tonight. I just want to take a moment to thank the board members too. It's been a lot of work to try and stay on top of this. It's a big, complicated system. And I really appreciate all the support you've given to us and to the staff over the last period of time. And that I know going forward, we're going to rise to the challenges as we meet them. We're fortunate, actually very fortunate in this country and in this province to have the leadership we had around the COVID crisis. We're fortunate that the number of people who died was kept to, obviously every one was a tragedy, but was kept to a number that, could have been much higher. And that, and we have managed to come through this with the minimum of damage to our society. Hopefully we'll continue on that. So again, if you've been listening to us tonight, thank you for joining us. Thank you for caring about the system. At the end of the day, we're just the caretakers. It's actually owned by everybody in this region and in this country in a way, but in this province. And so the more you take an interest in it, the more we want to hear from you. There are ways to get in touch with us as a board, etc. I encourage you to do that. I know that I value all the comments that I get from people because they're coming from a place of experience and mostly from a place of trying to make the system better. So again, I want to thank everybody for participating tonight and for the work you've done to help us through this. Anybody else would like to add anything? Happily, you go ahead. Any other board members or Victoria or any of the staff? It's fine. They all want to go home. That's good. Okay, again, thank you for joining us, and hopefully we'll see you again in August or maybe in person. Bye-bye. Good night, everybody.